Okay. Good morning, all friends. Welcome back to Saturday morning meeting. And today we have a very common topic of interest to all of us because dementia is a very dreaded thing. It happens to everybody almost. We'll know more about it from Dr. Kaushik Rana. He's a DM in neurology. He's a consultant neurophysician in Baroda. He did his MBBS and MD medicine from Baroda Medical College. He did his DM neurology from SMS Medical College, Jaipur. Currently, he's working as an associate professor in neurology at SBKS Medical College and as a consultant neurophysician at Prime Brain and Kidney Clinic and Savita Super Speciality Hospital. He has several publications, more than 25 publications to his credit in various international and national journals. And his areas of interest are headache, neuroimmunology, stroke, and epilepsy. So with this brief introduction, I request Dr. Kaushik Bhai to start his talk. You'll be talking for about 40-45 minutes and we'll have 10-15 minutes for discussion. So over to you, Kaushik Bhai, and thank you once again for joining us.
Okay. First of all, I'm very thankful to Satish Pandya sir and Amin sir for inviting me here to present myself in front of this elite group. I'm going to talk about dementia. Dementia is a very complex topic, and it is a clinical term. It is very difficult to complete this topic, represent this topic in this limited time window frame. So I tried my best to represent this complex topic in very simple form. Dementia is a clinical things. We need not to have some hi-fi test or MRI to diagnose patients with dementia. We just need to hear patient's story. If we hear patient's story carefully, then usually the diagnosis can be made from just based on history. So all my talk is based on how to approach a patient with dementia from clinical point of view, and what are the other types of dementia and what can be done in patients with dementia from the therapeutic perspective as well as to prevent it. Before moving to the discussion, this is a DSM-5 and DSM-4. This is a manual to categorize the mental disorder. Previously, DSM-4 was used. Now it is DSM-5. In DSM-4, dementia, delirium, amnestic disorder, they are categorized under one heading. Now they replace this terminology with neurocognitive disorders. But commonly, we are using dementia interchangeably with neurocognitive disorders. There is some difference between dementia and neurocognitive disorders. Dementia is a customary term. It mainly used for the degenerative dementia that usually affects older adults and usually denotes only one or two cognitive domains, that is mainly memory. Whereas neurocognitive disorder, it is a broader term. It usually affects other aspects of the cognitive domains. So what are the neurocognitive domains? Before understanding dementia, we need to understand the various cognitive domains, because the affection of these cognitive domains defines the nature of the disease and diagnosis. There are 6 neurocognitive domains: attention, executive function, learning and memory, language, perceptual, motor ability, and social cognition. Each cognitive domains is represented by different cerebral lobe. The first is attention. Attention is what? It is ability to attend specific stimuli without being distracted. There are 3 types of attention: sustained attention, selective, and divided. Sustained attention is maintenance of attention over a time. We test this by letter A test. In this letter A test, we ask patient to tap on the table while hearing a letter A. We read different alphabets, and when patients hear letter A, he has to tap. Then selective attention is maintenance of attention despite distractor. That is hearing number as well as letter. And we ask patient to count only letters. Then divided attention is attending two tasks within the same time period. And that is rapidly tapping while learning story. So there are two tasks simultaneously patients are learning. So where is the localization for this attention? Attention basically localized to represented by, there is a reticular activating system in the mid brainstem. The fibers from the reticular activating system goes to the thalamus, and from thalamus, thalamocortical fibers goes to various areas of the brain. So this circuit represents alertness or attention. So anything which affect any particular lobe, mainly frontal lobe, or diffuse cerebral injury, like in patients with encephalopathy, electrolyte disturbance, encephalitis, it usually leads to decrease in the attention. Second domain is language and memory. Memory, basically there are three parts: immediate memory, recent memory, and long-term memory. Immediate memory is we receive the information and retrieve it just without any doing some modification in the memory, like repeat a list of word or number. Then there is also another memory, working memory is also included into the immediate memory. That is ability to hold information for brief period and manipulate it, like backward digit span. In the backward digit span, we ask patient to tell 3 to 4 numbers and ask patient to repeat it backwardly. So this is a working memory. It is a part of frontal lobe. Then recent memory. In recent memory, we receive the information, we encode it, register it, and then retrieve it. There are, and usually recent memory represents days to 1 day to few weeks memory. There are two types of memory: verbal memory and visual memory. Visual memory is what we see, and verbal memory is what we hear. Verbal memory usually represents the left temporal lobe, and visual memory is represented by right temporal lobe. Then third one is long-term memory. Long-term memory are three types: semantic memory, that is memory for the fact, Independence Day, World Cup kab jeeta. Then autobiographic memory is personal data, like marriage date, school name. These all are autobiographic memory. And third memory is implicit memory, implicit or procedural memory, that is unconscious learning of skill, like driving a scooter or car. When we learn, initially it becomes it is difficult, but after learning it persists for the lifelong. How the memory formation occurs in the brain? There is a area, perisylvian region. Initially the input comes here. Then if it is immediate memory, the output goes from here. So this is immediate memory. What happens in recent memory? Input from this area goes to the thalamus, and from thalamus to the limbic circuit. So this is recent memory. And when it becomes long-term memory, the hippocampus will organize, distribute, and connect the memory to the appropriate area of the cortex. Like if it is visual memory, हमने किसी की जगह पे देखा है और कोई person को देखा है, then this memory goes to the visual association area. If it is some task, motor task, then it store into the motor association area. If it is some emotional aspect, then it store into the amygdala and frontal lobe. So there are various lobes for long-term memory. So where are the memories stored? In hippocampus, usually for semantic memory and episodic memory. The temporal lobe, the medial temporal lobe represents recent memory, and anterior and inferior part of the temporal lobe represents long-term memory. Prefrontal cortex is for short-term memory. And cerebellum and basal ganglia, they usually store the procedural memories. Then language. Language is divided into tested in three parts. Expressive language, by confrontation naming. We have to ask patient name of the object. Then fluency we can check. that is the semantic fluency and phonemic fluency. Then grammar and receptive language. In that we can ask patient whether patient is comprehensive or not by pointing command or performing task by verbal command. So these are the ways we can test language. Then executive function. Executive function is represented by the frontal lobe. It includes planning, decision making, working memory is also part of executive function. Then feedback utilization, that is ability to solve problem by using hint. Overriding inhibition, that is ability to choose more complex solution. Then mental flexibility, that is ability to shift between the two concepts. This is an example of Stroop test. In Stroop test, we ask patient to tell the name of a color. Usually the tendency of our brain is to read out the word, but we have to tell patient that they should not read but tell the name of the color. In patients with frontal lobe in dysfunction, they usually ignore this information and they just read out. They don't tell the name of the color, like this is a yellow color, but they read it as a green. Then another aspect is perceptual motor ability, in which there are various components: visual perception, that is Hemi Neglect; visual construction, that involves hand-eye coordination; then perceptual motor; praxis. Praxis is ability to perform learned movements, that is pantomime use of object to command. By showing hammer, we ask patient to use how the hammer is used. Then gnosis is integrity of awareness and recognition by recognition of face and color. We ask patient to recognize various colors as well as face. Then social cognition. Social cognition is also important domain. That is recognition of emotions, identification of emotions in face, that is positive as well as negative emotions. Then theory of mind, that is ability to understand another person's mind. उसके दिमाग में क्या चल रहा है? That is by a thought process, what are the desires, intention of other person. So all these are various domain. Now we will discuss what are the symptoms related to a particular domain, how the patient presents by affection of each domain. So attention, if attention is impaired, so patient may have difficulty in doing work in environment with multiple stimuli like TV, noisy environment, or there is difficulty in holding new information in mind, like recalling the numbers, address or task given, or difficulty in doing mental calculation. All things takes longer time than the usual. Usually inattentive patient in a common day-to-day scenario, they just go out of the room without switching light or fan, or while washing the hand, they just tap खुला छोड़ देंगे, like that. Then executive function, this is also important function. There is what is executive function? It is ability of the person to perform multi stage task or complex tasks. So patient may have difficulty in performing complex tasks or multi-stage task, like or planning of the function or some event. Like in simple word, if patient is housewife, then patient may have difficulty in cooking in the form of she may not recollect the necessary ingredient to make some sabji or rice. She may make error in judgment in the quantity, how to make, how much quantity is needed. Shape of the roti may be changed, taste of the food may be changed, and home cleanliness. So these are the symptoms. How patient presents to us with executive dysfunction. If patient is a shopkeeper, then patient may have difficulty in handling multiple customers at a time. Patient may have error in judging the quantity of items to be given, or difficulty in counting money. So these are the ways. If patient tells all these symptoms, that it indicates that patient may have executive dysfunction. And the localization for executive function is frontal lobe, prefrontal cortex. Then memory. Patient with memory impairment, they cannot keep the short list of items. They require frequent reminders. They have difficulty in recalling the recent event in the form of items eaten in the lunch or name of the guest visited 1 or 2 days prior. They often forget their keys, mobile or purse. Patient with the remote memory impairment, they often forget their distant relatives. Even in severe case of Alzheimer's, where remote memory is also affected, patient may forget their son names or daughter's name also. Then language. A person with language impairment, they can present with word finding difficulties, frequent grammatical errors while communications, and frequent pauses while communication. Patient may, there is stuttering speech, then difficulty in naming and understanding conversation because the impairment in language. The language is represented in the dominant temporal lobe, mainly left side of the temporal lobe. Person with perceptual motor disability, they have mainly disorientation, mainly difficulty in geographical localization. Like they requires map or others for the direction. They may get lost repeatedly, especially in the unfamiliar places. They have less precise in parking while car parking. They have difficulty in doing previously familiar activities like using tools, driving vehicles. They are part of apraxia. Sometimes patient may have ड्रेसिंग एप्रेक्सिया इन द फॉर्म ऑफ, मतलब पेशेंट ऐसा बोलेगा कि शर्ट पहनने में उल्टा सीधा शर्ट पहन लेते हैं और साड़ी पहनने में डिफिकल्टी आती है. So they require assistance of their family member to wear a clothes. Then Hemi Neglect. Sometimes patient with Hemi Neglect, they save only one half of the face or they eat just one particular segment of the plate. This perceptual motor ability is represented by the parietal lobe. Then social cognition. Social cognition is a function of frontal lobe. The behavior is out of the acceptable social range. Patient may have reduced social interaction, apathy, or impaired motivation to do some work. They have less feeling, less concern towards the family member. Or some patient may become antisocial behavior, emotional incontinence, or some patient may develop obsessive compulsive behavior. One of my patient son tells that कि उसकी mother उसको मतलब पहले जैसी नहीं रही, मतलब कि जब वो लेट आता था तो ऑलवेज मतलब पहले पूछती थी कि भाई क्यों लेट हुआ, खाना खाया कि नहीं हुआ. नाउ दैट पार्ट हैज गॉन. उसका कुछ उसका बेटा या डॉटर्स गिर जाती थी, रोती थी तो पहले उसको जाके उठा लेती थी. नाउ शी डजंट केयर कि रोती है तो रोने दो. सो दीज आर द things which can patient may become apathic. Then antisocial behavior. Patient previously used to remain calm, now becomes aggressive, using abusive language. Then emotional incontinence means frequent crying and laughing at inappropriate places. And obsessive compulsive behavior in the form of some patients, they develop they increase the ritualistic behavior. सुबह शाम पूजा करते ही रहते ऐसे. So social cognition is a function of frontal lobe. This is a mild neurocognitive disorder as well as major neurocognitive disorder. Previously we used MCI, that is minimal cognitive impairment and dementia. The mild neurocognitive disorder is patient or the relatives, they have concern about the declining in the cognitive function, but it is not such an extent that it will interfere their daily routine activity. Whereas major neurocognitive disorder or dementia, when we call it, when it interferes with their daily routine activity, patient needs some assistance from others to do their routine activity, then we can label it as a major neurocognitive disorder or dementia. Now, after symptomatology or cognitive domain, we will move towards case. This is a 71-year gentleman, retired bank officer. he presented with 2 years progressive history of memory disturbance in the form of always repeating himself, then often misplace the items, difficulty in naming object and distance relatives. Frequently, he forgot to take medicine, and he requires a regular reminder from his wife and son. He is able to go outside, but there is no history of any pathfinding difficulties or getting lost or any behavior changes. There is no history of any hallucinations, tremor. On examination, only he lost point in the recalling the names. All other higher mental functions are normal. So based on the history, we can come to know that patient is having impairment in the memory cognitive domain. So this is a classical case of Alzheimer's disease. Alzheimer's disease has main disease burden over the mammillary body and hippocampus. These are the screening tools we usually use in patients with dementia. That is MMSE, that is mini mental status examination. There are various components of it. And second one is MOCA, Montreal Cognitive Assessment Tools. Based on this, we can come to know whether patient is having impairment in cognitive domain or not. And then we have to assess in cognitive functions in detailed manner. So, few words about Alzheimer's disease. Women have nearly double the lifetime risk of developing Alzheimer's as compared to men, and incidence increase significantly after the 7th decade. What are the risk factors for Alzheimer's? There are non-modifiable risk factor and modifiable risk factor. Non-modifiable risk factor, they are like age. As the age progresses, chances of Alzheimer's are increased. ApoE4 heterozygotes. If patient is having these phenotypes, then there is high chance that the patient may land up in with Alzheimer's disease. Then certain genetic factors like amyloid precursor protein, presenilin 1 and presenilin 2 gene mutation, all these patients, they develop Alzheimer's at an earlier age group. Then certain modifiable risk factors in the form of diabetes, orthostatic hypotension, hypertension, hyperhomocystinemia, obstructive sleep apnea, they are the modifiable risk factor. By modifying that, we can somewhat alter the nature of the disease. This slide represents what are the types of combinations of dementia. If we see that Alzheimer's disease only, there are very less percentage, but if we see this Alzheimer's with other neurodegenerative and vascular dementia, in routine practice, we often found that there is a combination of disease, like some the patient is having Alzheimer's associated with vascular dementia. So mixed dementia is very common nowadays. This is a pathophysiologic process, how the patient with Alzheimer's or vascular dementia can develop dementia. The risk factor in the form of hypertension, smoking, diabetes, AF, dyslipidemia, it leads to cerebrovascular disease by atherosclerosis or amyloid angiopathy. It leads to vascular brain injury in the form of infarction or hemorrhage, and ultimately disrupt the cognitive networks. And ultimately, patient develops vascular impairment and dementia. If patient is having associated genetic risk factors like ApoE4 heterozygotes, then patient have deposition of amyloid beta protein as well as p-tau protein, and this leads to amyloid angiopathy, and it also disrupts the various cognitive networks, and ultimately patient develops Alzheimer's disease. Now, this is a life history of patients with Alzheimer's. Initially, patient presents with mild symptoms in the form of some cognitive symptoms like misplacing items, forgetting appointment, as I have told in my case, then some form of mild neuropsychiatric symptoms and sleep disturbances. As the duration of disease progress, and patient may develop severe disease, and the severe disease patient have developed apraxia, forget their familiar members, and severe aphasia. Some patients develop hallucination, apathy, seizure, incontinent. So as the duration of disease increase, the severity of Alzheimer's disease will also increase. This slide represents age of presentation and combination of the symptoms. As we know that younger the age, there is higher chances that other cognitive domains are affected, like judgment, then language, visuospatial functions. So patient with younger Alzheimer's disease, they have involvement of other cognitive domain, whereas the elderly patient, they have majority impairment in memory function. These are the biomarkers used in a pathophysiological process of Alzheimer's disease, that is amyloid beta plaque, tau, and neurodegeneration, that is tau protein. Depending upon the deposition of these amyloid plaques or tau protein, there are various types, atypical forms of Alzheimer's disease. In typical Alzheimer's disease, the disease burden is mainly in the hippocampal region, that is amnestic variant, whereas some patients, they have disease burden over the occipital region. It is known as posterior cortical atrophy. Some patients, they have disease burden over the language area, and it leads to primary progressive aphasia. And some patients have other area of the brain, it leads to non-amnestic Alzheimer's disease, in which the forgetfulness is less as proportional to the impairment of other cognitive domain. Then behavioral Alzheimer's disease, in which the disease burden is mainly in the frontal lobe. Then corticobasal syndrome. Posterior cortical atrophy, I'm not going to details about this, but just there are various syndrome. They have described Balin syndrome, Gustman syndrome, then prosopagnosia, alexia. That just one important thing. This is a figure, ray ostrich complex figure. If we ask patient to draw this figure, so we see that the small component of the figure are very well drawn, but the overall concept of the figure is missed. See, every small details of the figure are very well drawn, but the overall concept of the figure is missed. This is an example of simultagnosia. It is seen in patient with parieto-occipital lobe degeneration. This is also another example of simultagnosia. Patient tells that the letter is T, but patient cannot see the large picture, that all the T, they form letter H, or the this picture. Patient with simultagnosia, they can able to distinguish, tell that this lady is pointing towards the mouse, this person is carrying the T, but it cannot collect all this information, tells that all the family members are taking the lunch or breakfast together. So these are the way a patient can present. Now, after Alzheimer's, another case, 58-year male, presented with 1 year history of progressive personality and behavior changes. His behavior become childish, inappropriate laughing at odd places and situation. And he spent so much time in the puja or any religious activity. And patient did not exhibit any empathy or sympathy towards his family member. Sleep was reduced from 7 hours to 4 hours. And since last 6 months, patient develops forgetfulness of the recent event, like missed medicine, social engagement, and patient also developed difficulty in managing financial aspect. So from the based on history, we can come to know that these all are part of social cognition. These are the memory impairment, and this difficulty in managing financial aspect is a part of executive function. So patient is having mainly involvement of the frontal lobe and some form of temporal lobe. So based on the history and 1 year history, it suggests some degenerative process. So based on the history, we can come to know that patient is having frontal lobe degeneration as well as temporal lobe degeneration. So The diagnosis of this patient is probably patient is suffering from frontotemporal dementia. These are the pictures of this patient at various age, at 58 to 66. As the age progresses, we can see that the frontal lobe as well as the temporal lobe. There is severe atrophy of the temporal lobe as well as frontal lobe in this. The frontal lobe is more atrophy as compared to the occipital lobe. So, patient with frontotemporal dementia, usually they present with frontal lobe dysfunction in the form of behavioral disinhibition, apathy, loss of sympathy, empathy, hyperorality, executive dysfunction, and perseveration or compulsive behavior. What is sympathy and empathy? Sympathy is patient tells that I am sorry that you are in pain, but patient with empathy, they can feel your pain. So there is loss of sympathy as well as empathy in patients with frontal lobe dysfunction. Case 3, 54-year male, is hypertensive, had 2 stroke, 1 year back and 4 year back. 1 year back he had right hemiparesis, 4 years back ataxic hemiparesis. Patient was on regular medicines for antiplatelet, statin and hypertensive agent. Now the patient developed difficulty in handling customers and managing shop since 1 year. He make frequent errors in counting monies, often forget his keys, mobiles, and frequently searching for it. Patient is blood pressure is on little bit on higher side. On higher mental function examination, there is impairment in attention and frontal executive function as well as resentment. And there is little bit hyperreflexy and spasticity. Long track signs are also there. This is patient's MRI. This so that there is hyperintensity in the subcortical region, frontal, parietal, occipital, and temporal region. This is ischemic demyelination. So patient with recurrent stroke, hypertension, and I forget to tell, this patient also had a history of repeated attacks of migraine with subcortical hyperintensity with temporal lobe involvement. So this is a classical case of CADASIL. What is CADASIL? CADASIL is a genetic condition, cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. This is a genetic disease which affects young patient, recurrent stroke, patient hypertension, and history of migraine. So this case explores the another aspect of dementia, that is vascular dementia. What is vascular dementia? It is dementia due to vascular pathology. So what are the types or pathophysiology of vascular dementia? We may get large artery stroke like carotid stenosis or occlusion. It can lead to the strategic infarct in the temporal lobe, frontal region or occipital region, and leads to post-stroke dementia. And these are the vessels which are deep-seated small vessels. The pathology could be atherosclerosis, arteriosclerosis, or arteriosclerosis. So this can lead to lacunar infarct or leukoariosis, deep microbleeds or lacunar infarcts, or in cortical region. The pathology can be atherosclerotic occlusion, leads to local cortical infarct, or cerebral amyloid angiopathy. This can lead to cerebral microbleeds, lobar hemorrhage. So what are the types of vascular dementia? Post-stroke dementia, that is patient may have a strategic infarct in some particular lobe, and that lobar functions gets impaired. Then subcortical vascular ischemia, as in my case of CADASIL. Hello. Then multi-infarct state, patient may have repeated attacks of infarct. Then mixed dementia. So this slide represents the microbleeds. These are the hypertensive microbleeds in the subcortical regions, and this is microbleeds due to amyloid angiopathy. These all are the predisposing factors of dementia later on. If any patients we found that they have microbleeds in the subcortical region or lobar region, so this patient may end up with dementia later on the age group. Now, case 4. 65-year woman with hypertensive presented with 4 weeks history of slow halting speech and confusion and disorientation. And 1 month back, she developed acute onset of the blindness. Ophthalmic checkup was normal and she treated as PCA territory stroke. She came to us for second opinion. On examination, patient was confused, disoriented. She had myoclonus, rigidity, and extensor plantar response. This was her MRI. As we see that there is some hyperintensity in the cortex. This one, this is a frontal lobe, this is a temporal lobe, and this is occipital lobe. And her EEG showed this is a spike wave discharges which occurs every 1 second. Generalized discharge occurs every 1 second. So this is a generalized periodic discharge. So with combination of rapidly progressive neurocognitive disorder with MRI findings suggestive of cortical ribbing. This is known as cortical ribbing. Only cortex are affected. No other structure of the brain are affected. And EEG suggestive of periodic discharge. This is a classical case of CJD, Creutzfeldt-Jakob disease, Prions disease. So this case highlights the another aspect of the dementia, that is rapidly progressive dementia. The causes of rapidly progressive dementia can be told by acronyms, vitamins. V for vascular disease like stroke, CADASIL, then I for infection, T for toxic or metabolic disease like electrolyte imbalance, vitamin deficiency, then metals deposition, and autoimmune conditions like encephalitis, multiple sclerosis, then metastasis, iatrogenic by some drug, extrapontine myelinosis, then certain neurodegenerative process, they can develop rapidly, then some systemic structural or seizure like convulsive status epilepticus, hypercarbia, hydrocephalus, NPH, or structural lesions like subdural hemorrhage, STH. So these are the rate of progression, the fastest presentation of this autoimmune, metabolic, iatrogenic, infection, and systemic. And we also know that there is potential reversibility. These are the very reversible dementia. Then CJD is also fast, neoplastic vascular later on, and then slower ones are neurodegenerative. Few words about CJD. It's a fatal spongiform encephalopathy. It's a prion disease. Mainly sporadic cases are seen. Usually the age occurs in the 7th decade. The clinical features of CJD are progressive cognitive impairment associated with myoclonus, visual impairment, cerebellar signs, pyramidal, extrapyramidal signs, or akinetic mutism. And MRI, as I told that there is cortical ribbing as well as hyperintensity in the basal ganglia structure, caudate, putamen, thalamus, and EEG is showing periodic sharp wave complex. This is the hyperintensity in the putamen as well as caudate nucleus, and this is a thalamus, medial thalamus, and cortical ribbing. So this is images of CJD. Now, autoimmune encephalitis usually presents young patient with altered sensorium, rapidly progressive dementia with seizure, and in MRI, if we see the hyperintensity in the temporal region, this is the temporal lobe. This usually represents either autoimmune encephalitis or limbic encephalitis in case of elderly patient. Sometimes paraneoplastic encephalitis can present like this. Then this is Wernicke's encephalopathy. There is hyperintensity in the medial thalami. Usually, Wernicke's encephalopathy is due to thymine deficiency. Thymine has a half-life of 6 to 7 days only. So, if any patient, they are nutritionally deprived, like some elderly patient, they have decreased oral intake. So, they may have tendency like to develop Wernicke's encephalopathy. Then if we see hyperintensity in the T1 image in the basal ganglia, it represents hepatic encephalopathy or hyperammonemic encephalopathy. I have diagnosed 2 or 3 retrospective based on MRI that patient developed cirrhosis, patient diagnosed as chronic liver disease based on MRI finding. Patient present with altered sensorium on MRI. These are the findings. These were the findings, and later on we retrospectively do USG, and then we found that patient may have cirrhosis of liver. Then vascular dementia, then CNS vasculitis. This is the contrast enhancement in the pial vessels. So all these are the course of rapidly progressive dementia. So treatable dementias are infectious dementia, metabolic cause, electrolyte disturbance, subdural hemorrhage, or autoimmune causes. Now, moving to treatment aspect. As such, for degenerative dementia, there is no definitive treatment, but we can recognize and treat the comorbid medical factors like sleep disorders, adverse drug effect, mood disorders, alcohol misuse, then de-prescribing medication which affect the cognitive. There are so many medications we are using frequently that can affect or decrease the cognition, like MSEC, certain painkillers in the form of tramadol, certain antibiotics. So all this can lead to decrease in the cognition. And treatment of the underlying neurodegenerative condition. The pharmacological treatment for dementia. Donepezil, there are 2 category of drugs which we can use. Acetylcholinesterase inhibitors. It includes donepezil, galantamine, and rivastigmine. Rivastigmine can also available as a patch form. In patient with severe dementia, if patient is not able to take orally, then we can use this transdermal patch. The side effect of all these drugs are nausea, vomiting, diarrhea, dizziness, cramps, bradycardia. Then another category of drugs we can use are NMDA receptor antagonists, that is memantine. We can use a combination of drugs like donepezil plus memantine combination in moderate to severe dementia. So if patient is having some aggressive behavior, then we can use antipsychotics also. Patient with depressive symptoms, we can use SSRIs. Now, after treatment, preventive aspect. This is a meta-analysis of various studies. This is a very important slide in this lecture. From infant, they have analyzed from infancy to the elderly age, and found there are various factors which can alter or change the course of the disease. They found that the protective factors are more schooling, more education, then cognitive activity, then healthy dietary pattern, then physical exercise, small weight, and vitamin C. So if we do all this in this age group or early age, then we can somewhat delay the development of dementia. Then these are the risk factor for development of dementia. So we have to modify this, like smoking, head injury, hypertension, stress, obesity, depression, diabetes, sleep disturbance, and cerebral microbleed. So if any of these factors are present, then we need to treat them also. (120/80), we have to avoid hypotension. Glucose level should be less than 100. Cholesterol should be under control. Smoking should be avoided. Then physical activity should be there. Overweight should not be there. Then in diet, fruits, vegetables, fish, then fiber-rich grains, low sodium diet, and sugar sweetened beverage should be avoided. So these are the preventive aspect of the dementia. And the last one is mental fitness. We all there are so many talks about the physical fitness, but no one is talking about mental fitness. So what are the ways how we can achieve mental fitness? There are so many ways, by doing meditations, physical activity, avoiding multitask, healthy relationship, doing something new, and some brain challenging activity. So these are the ways we have to implement at early age group. So this can delay the development of dementia. And last slide is psychological aspect of exercise. It improves attention as well as concentration. It sharpens the thinking, judgment, and learning skill. It enhances memory, creativity, energy, and there is a improvement of self-esteem and self-efficacy. So, summarize my talk. Diagnosis of dementia is purely clinical. We need to spend time with the patient and hear their story. We need to identify treatable causes of dementia. Pharmacological therapies are there. It will produce mild to moderate benefit. And identification of disability. तो पेशेंट को क्या डिसेबिलिटी है उसके हिसाब से उसकी ट्रीटमेंट होनी चाहिए. And caregiver education is also utmost important, because many times patient may do some activity which is not in their hand, like light या पंखा बंद किए निकल जाना. So we need to educate the caregiver. भाई ये उसके डिसेबिलिटी का पार्ट है, नॉट पेशेंट जानबूझ के नहीं कर रहा. Then preventive measures, they should be started very early in the life, and health education is required, and mental fitness is the required to prevent or delay the course of dementia. Thank you.
Thank you, Dr. Kaushik. Wonderful. Such a common topic, and we had so many questions in our mind, and you answered most of them. If you can please stop the screen sharing, we can start discussion. Yeah. So that was wonderful, and I would say that attending Saturday Club morning meeting every Saturday is also a preventive measure.
Yes, sir. Yes, sir.
Keeping up the education. I have few questions to start with, and we'll take up others. You mentioned about some drugs which can cause dementia. So
yes.
What are the common drugs?
So mainly sedatives. Sedatives like clonazepam, then antipsychotic medications, then SSRIs, then certain antibiotics like linezolid.
Okay.
Recently, we published a papers on serotonin syndrome.
Okay.
There are certain drugs which will lead to serotonin toxicity, like this linezolid, MSET, which are commonly used in ICU setting. So patient admitted for certain disease, and they'll end up with cognitive disorders. Contramol, tramadol is also such common drug.
Oh.
So these are the drugs which should be used judiciously.
So they are, if they are used for a long time, they will cause this issue short term, right?
And some patients, they have tendency to develop this, like if patient is having degenerative brain, and if we are using this tramadol for short period, then there is a chances that patient may develop dementia, altered sensory.
This may precipitate the process further. There is a question about, it's a good question from Dr. Sabnam. How amnesia is different from dementia?
Ma'am, amnesia is basically memory loss. And dementia is a broad term which includes all other cognitive domains which I have mentioned.
And Dr. Sulin has a question about migraine causing this dementia. You mentioned about migraine in one of your slides. So elaboration on that.
Migraine alone will not produce dementia, but there are certain conditions, genetic conditions like CADASIL, which is an autosomal dominant condition due to mutations of Notch1 gene. In that, the clinical features is migraine, hypertension, and stroke. So migraine alone cannot produce dementia.
Right. And He has also a question regarding any subclinical stroke known to cause. He's talking about stroke.
Yes, sir.
Is there any entity called subclinical stroke?
Yes, sir. Sometimes the lesion at some region which may not produce clinical deficit. Like some patient, I have seen so many patients with occipital lobe infarct. They may not aware that the stroke has happened. We retrospectively diagnose, like on CT scan, MRI, there is some gliosis in the occipital region. Then we come to know that patient developed stroke earlier.
Right.
And
so I have finished. Yeah.
Yes.
Please go ahead.
A problem with dementia patient is anosognosia. Patient himself, they may not aware their deficit, and usually all the patients, they are retired person. So family members, they may also not aware about the disability when the severity is so severe. So all whatever I encounter, all the patients, they almost in the advanced, moderate to advanced stage of the dementia. In mild stage, sometimes they think that it is because of age-related things or something like that.
Right. So I have finished these questions from the chat box. Now we can have questions from the audience. Dr. Jagdish Bhai would like to ask.
Yeah. Long-term use of PPI and statins. Some reports say that they may lead to dementia after long-term use. Is it true? Any studies you know of?
Yes, sir. So there are so many studies. We suggest that there are controversial evidence in the some statin study. They say that it progresses the part of dementia, and some study found that it reverses, it prevents the development of dementia. So it is a
There is Jagdish, any more question from you?
Another question was that most of the time in senior people, we find that they are speak same thing repeatedly.
Yes, sir.
Will you stay for dinner? Will you stay for dinner? You have replied again. Then they progress slowly.
Yes.
So can we say how we can say that dementia will increase? What is the rate of increase?
Sir, this repetition of the same words or repetition of same task, this is also a part of frontal lobe. It is known as perseveration. Patient may repeat the same words or doing some activity. We test by I often in my OPD practice, I ask patient to follow my command. I tap for 3 times and ask patient to repeat it. Sometimes patient with frontal lobe, they kept on clapping. So this is a involvement of frontal lobe.
So it's an initial stage.
Yes, sir. These are
how fast they were. Yeah, how fast they progress then.
Sir, depending upon the etiology, if the degenerative process is there, then it can progress slowly. But simultaneously, patient is having a risk factor like associated vascular dementia, hypertension, diabetes. Then the rate of progression is fast. So we cannot change the natural history of FTD, but we can change the other modifiable risk factor.
Do medicines help in such cases? What Jagdish Bhai described is very common actually. Beyond 80, I have seen a lot of my relatives who just keep on telling the same thing again and again, but otherwise they are fine.
Sir, I think at this stage, there is no need to give any medicines.
Okay.
Because what we are treating is the disability of the patient. If patient is not having any disability, just mild form of some cognitive impairment, then it doesn't require any treatment.
Okay. And there is a question and comment from Dr. Jagdish Chinnappa, the pediatrician from Bangalore.
Yes.
He has complimented you for giving a super talk, and he has 2 questions. How does social isolation precipitate dementia? And other question is, does anger prevent dementia?
Sir, one thing for the first question, social isolation. Usually all the dementia, the process starts after the retirement of the persons. When the as I told in my talk, that mental fitness is required. So after retirement, all the mental exercise patient is doing is stop. So a patient remain isolated at home. There is some loss of self-esteem. कि भाई अब retire हो गया, अब क्या होगा? Then the family members are out of the for working. So patient, the retired person is remain at the home majority of the time. So this kind of the things will aggravate or mask the symptoms of dementia. Sometimes patients are well do in their home, but when patient go outside the home at some unfamiliar places, then he may find some difficulty in adjustment.
And about anger preventing dementia. He's asking about, does anger prevent dementia?
No, sir, there is no such things. As the stress, anger will lead to stress over the brain, and it will produce some decrease in the concentration, attention.
Yeah, so that's why we all talk about anger management. Here his question is actually raising another thing, whether anger should be helpful or not. Anyway, so yeah, there is one more comment from Dr. Shabnam Mansuri about hypothyroidism relating to dementia.
Yes, yes. Ma'am, I have there is one terminology just I forget to mention in my talk. There is STREET. That is steroid responsive encephalopathy treated with associated with thyroiditis. I have seen 1 or 2 patients with hypothyroidism. They presented with dementia, and they are highly responsive to steroids. It is an autoimmune condition of associated with hypothyroidism, autoimmune thyroiditis, which associated with dementia. One is Hashimoto's encephalopathy and STREET. So these 2 conditions are associated with dementia, and they are easily treated with steroids. And one is thymine deficiency. Thymine is associated with as I told, the half-life of thymine is only 7 to 8 days. So any elderly patients or alcoholic patient, if they are nutritionally deprived for 7 to 10 days, they are bound to develop thymine deficiency. And thymine affect the medial thalamus, which has role in the limbic system. So thymic deficiency can precipitate forgetfulness. So in our institute at Dheeraj Hospital, we used to give high dose of thymine. The traditional we used to treat a patient with dementia or delirium with high dose of thymine, at least 500 milligram per day for few days. And some patients, they show dramatic response to thymine.
Thank you for very elaborate and useful answer. So I think there are no more questions now, and it's already, time is up. There is one comment. People are advised to play games like, Sudoku to keep stimulating the brain to postpone dementia. Is it true? I think you answered this question, but you can still elaborate on that.
Yes, sir. Because any activity which utilize our brain, I think we have to use all aspect of the brain: frontal lobe, temporal lobe, occipital lobe.
In a lighter way, when I was doing my vocal music for 4 years, diploma, every evening 2 hours I was spending learning classical vocal. People used to ask me, why do you spend so much time? I said it is for prevention of dementia. So I think any activity which stimulates your brain is good to carry on.
Like, sir, just one thing. In our routine day, we just do at our spinal level. के घर से निकले, hospital गए, patient देखा, वापस आए. But if any change in by changing the route of going hospital, that will also stimulate. कि ये रास्ते से जाना है, इतना time लगेगा. Or for housewife, if they are preparing routine meals, so it occurs on spinal level. But when they made some novel items, so they started using their brain. कि ये बनाना है तो इसमें ये डालना पड़ेगा. That will stimulate. So we have to try different activities.
Yeah, we doctors don't retire as such, so I think most of us
Yes.
would not suffer from Alzheimer, hopefully.
Yeah, yes.
Okay, so thank you everybody for attending this very informative talk, and thank you, Dr. Kaushik Bhai. I think we will have many more talks from you because your talk was very informative and it cleared so many cobwebs in our mind regarding dementia. So thank you very much.
Thank you, sir.
We meet next Saturday again, and our speaker will be Dr. Jagdish Bhai, who is going to review a very interesting book, which I will announce through a flyer. So thank you all. We end the meeting here. Thank you.
Thank you, sir. Thank you.